Hello, everyone. We'll wait a few minutes for everybody to start coming in. Thank you so much for being here. Happy Wednesday. I'll give it just another minute here and share my screen to get started. All right. Excellent. Wait just another moment here while people are just coming in. Wait till 6:04. So, wonderful. All right, I think we can go ahead and get started here. Welcome everyone tonight. Thank you so much for joining us tonight for this really great webinar from that's hosted by Agitated Solutions. This webinar is called From the Reading Room: Confusing Bubble Studies. I will be your host tonight. My name is Maddie Jankowski. I am a cardiac sonographer at Northwestern Memorial Hospital in Chicago, also a researcher at the university, but I am also the clinical specialist for Agitated Solutions. So I'm really happy to be hosting tonight two of my good friends, Dr. Micah Eimer and Dr. Ben Freed. If you two want to go ahead and introduce yourselves.
Mike, after you.
Ben, no, you should go first.
No,
No,
okay.
you're far more important than I am. Please.
You're more handsome. Um, I am Ben Freed. I am a cardiologist, non-invasive at Northwestern. My expertise is in echo and MRI, and I've really excited to be here because I get to be with Maddie and Micah again, and that's always fun. It's like our conversation usually, but just recorded and in front of a lot of people. So,
Um, well, thanks, Ben. My name is Micah Eimer. I also a general cardiologist at Northwestern. Also do a lot of echo work. I work in one of our community hospitals to the north of the main hospital where Dr. Freed is. And I'm excited to be here as well. You know, often we're reading these studies in the dark, 8 o'clock at night, and you're like, I don't know what I'm looking at. And it's fun to be able to bounce things off people, people as experienced as Maddie and Ben, and kind of say, hey, what would you do with this? So I'm looking forward to this, and looking forward to learning something, and hopefully making something entertaining as well.
Thank you both so much. So how this is going to work tonight. So here's Ben and Micah in the reading room. And so we are in our virtual reading rooms right now, but think about kind of when you're in the echo lab. And just like Micah said, this is really, we don't really get a chance as often anymore to sit with our colleagues and really go through some of these cases. And so please, while we're going through these cases, we'll kind of have a case and then a little break. And so go ahead and ask your questions. If you have things to ask, you can ask them right after those cases. We'll also have a little bit of time at the end. But this should be really interactive and hopefully we all learn something. So let's go ahead and look at some bubbles. So, case one that I prepared for you two is a 65-year-old female with a history of coronary artery disease. She has a couple stents placed, and she's being evaluated for a lung transplant. And so she had a dobutamine stress echo ordered that also included a bubble study to evaluate any concern that there is there. So I'll leave it at that and I'll give you the first bubble study. So here we are at rest. Okay, we see nice bubbles. All right. Hopefully this was a little bit of an easy one to start you guys off with. So first, what I want to do for this is, talk about obviously what the diagnosis is, but I really want to talk about, how well we're seeing these bubbles in this bubble study. So do you guys think that, I think this is pretty good opacification of this.
Yeah. I mean, I thought you were going to show us some disaster. This actually, you can see bubbles, you can see the chambers of the heart, you can count. I mean, this, I'm happy to see this is our first one.
Yes. Yes.
They're all
So
like this.
Yeah.
yes, of
At
of course.
Northwestern, they are. Yeah.
Every bubble study we have. So, but looking at this though, this seems like maybe the bubbles didn't arrive right away. And so I'm going to go ahead and play the Valsalva clip for you as well, just so you see that. And then we'll talk about kind of what those findings were. So
I
here's the
counted
Val.
like 5 cardiac cycles, maybe. It's 4 to 5,
Okay.
something like that. Yeah.
Oh.
Oh, whoa. What is that? Okay.
Quite a lot of
That's
bubbles.
that's a lot of bubbles.
That's a
And
lot of bubbles.
earlier. And earlier.
Yes.
It did look like earlier, didn't it?
Much earlier.
One thing that's interesting, so I thought this was like, I would call this like a large shunt, right? Whatever shunt it is, we're
Yes.
opacifying like the left ventricle. So it's a really big shunt. Would you even attempt to count bubbles in this?
I can't count that high, Maddie.
That's like the jelly beans, when you are asked to count how many jelly beans are in there and you never get it right or even
Yeah.
close.
Yeah.
And that
So,
so the answer is no. That's what I meant by that. I would
yes.
not count how many bubbles are in there.
I don't think I would try to count this either. I think when we
A
see
lot.
that big plume and like they almost look like
Yes.
contrast bubbles.
Yeah.
And so, but one thing I found interesting, I'm gonna just pause this and play it, kind of pull through a little bit. I thought that we could see these bubbles starting to come from right
Oh, yeah.
there,
Yeah.
from that side of the atrium.
Yeah.
But this was weird because I don't think that that was like that looks like, only a couple cycles. Let's see. One, so there's it filling. So
Well,
one,
but I mean, Maddie, this is a mess because like, do you start counting from the first right-sided bubbles that you see? Do you start from peak opacification? Like, we don't all agree necessarily on where we're starting to count, is my guess.
yeah. With this type of study, I guess, I typically look when it's at least the RA is completely opacified. When
Okay.
you two are reading a bubble study, what do it's definitely challenging to say, that was 3 cycles. Okay. The RV is totally opacified. How do you two go read that, even if it differs from what other people are doing?
I wouldn't start counting until the RA was opacified. I mean, if it's really sluggish and the bubbles are having a hard time getting in, then I wouldn't start counting the moment I start seeing a few bubbles in the RA.
Hmm.
Um, so I would wait until I felt like the bubbles were close enough to cross over if that's what's going on or not.
Yeah.
Yeah, and this is actually a good example. You see great contact, great opacification at the interatrial septum, which yeah, right there. Like a lot of
Yep.
times, there's competitive flow from the eustachian valve and the bubbles don't get up in there. You can see the bubbles getting all up in there. But what's interesting is it looks like they're actually coming from the non-septal side of the atrium, suggesting that maybe they're pulmonary in etiology. So a little confusing here.
Yeah. So I think, but with this, so say that we called this a PAVM and going back to the patient's history, so she is getting worked up for a lung transplant. What does this really positive bubble study mean for her?
So let me back up just a little bit because um, I think what's interesting here is that you showed us the first time around without Valsalva, right? And
Yeah.
it was delayed in that one. And
Hmm.
that immediately should make you think maybe it's an extracardiac type of AVM, um, probably pulmonary. I think the fact that when then you showed it with Valsalva and it seems much more abrupt and shorter duration is it's a little weird because I mean you wouldn't necessarily expect this maneuver if it was an AVM to really help you know with getting the bubbles across. So you expect that in an intracardiac shunt.
Yeah.
Yet the location of the bubbles where it seems to be coming from, which a lot of times we don't always see, it's kind of hard sometimes to actually see in the left atrium where those bubbles are starting from, you know, do make you think that maybe this still is, it's not coming from the septum, it's coming from the pulmonary veins there into the left atrium. So it's a bit of a confusing picture, I would say. I don't know, Mike, if you
I'm going to play you one more clip before so the sonographer was very astute and kind of did a zoomed view of that atria to really help see where this was coming from. Let's see if this one shows us a little better, kind of keeping that inner atrial septum open more. I think we might have both.
Yeah, that would be, I mean, 25% of people have a PFO, which means 25% of people with PAVMs also have a PFO, I think, right? So it's possible.
also do
Defies
we
Occam's razor, but
Yeah.
that's a lot of bubbles if it was just a PAVM. I mean, I don't know. It just seems like there is some bigger intracardiac shunt going on, maybe in addition to an AVM, but um it's an oddity.
Definitely a confusing one, right?
yeah, good job
Yeah.
on confusing us. Yeah,
Yeah, nice.
So I
But
guess
it's a
just,
good quality one. So
it
yeah,
is
nice.
a good quality for
Yeah.
sure.
Yeah.
very good quality. But yeah, I would think that this patient would probably do well for a TEE just to
Yeah.
see better visualize that inner atrial septum. But going back to just my quick question that from my understanding in doing dobutamine studies with a bubble study is that, for these liver transplant workups, is that if they are positive for these PAVMs, that may not be a good outcome for them. Am I thinking about that correctly? In
This is
a
a liver
liver
transplant.
liver transplant, yes.
Oh, you said lung on the first
Oh,
line. Yeah,
okay. I'm sorry. I meant liver.
gotcha. Okay. That
That's
makes more sense. Yeah.
yes.
Yeah.
Um, Yeah, I mean, it is. Liver transplant patients have a fair amount of pulmonary shunting, right? And hepatopulmonary syndrome, and there's a type 1, type 2, but they both have it. Now, the good news is that transplant cures it for them, but if it's severely severe, that can become an operative problem and could make them not a candidate. So I think that's why the transplant folks have us doing these is to get
Mhm.
more information on that.
Yeah, I definitely think just for these lung trans or I keep saying lung, liver transplant studies in general, making sure the sonographers that you are obtaining a long enough loop so you can see the PAVM, so you can see late bubbles. I think, if this would have been a little later, we could have missed it if the clip was short enough.
So Ben, what
Yeah.
would you do with this patient to help sort this out?
You mean in terms of seeing where the etiology is?
Yeah, yeah,
I mean, I think a TE is reasonable. You know, it would be nice to be able to do some imaging of the lungs to see, or the vasculature to see if there's AVMs, which
yeah.
is not always that easy. Um, I think part of the question is how is it going to change management, right? Because if it is hepatopulmonary syndrome, as you mentioned, Micah, that you want a transplant. I mean that's because the problem here is that the capillaries are so dilated, right, that you're getting that shunting, right? But
Yeah.
your PA pressures are supposedly normal or maybe a little mildly elevated, but not prohibitive from doing surgery. But certainly you would want to make sure, you know, for instance, if you do have a big shunt, and you think that there's a lot of right to left intracardiac shunting, you want to make sure there's no PH or pulmonary hypertension going on, like portopulmonary disease or something along those lines, because certainly that can be a problem when it comes to surgery. Um, so I think you would have to try to differentiate that to some degree. The chances of that are not high, given that the right side of the heart doesn't look like a PAH type picture, right? There's a significant precapillary pulmonary hypertension going on. But nevertheless, I mean, especially with our transplant folks, we kind of do everything possible to make sure that we have as definitive answers as we can before they undergo transplant for obvious reasons.
Great. Well, I think this continues to be a confusing one. We'll move on to the next case. So case two is kind of a series of cases, and this is good versus bad, bubbles and maneuvers. So we're going to go through a couple cases, and I just want you guys to comment on kind of the quality of the bubbles and or the maneuver. So this first one is a bubble study with Valsalva. And so let's see if they kind of appropriately changed those pressures in the heart. So an okay image here. Oh, oh, look at that.
Oh, wow. Okay.
I'll let that play a couple times. So kind of as this is playing from a sonographer perspective, this, you know, isn't the most textbook quality image, but I do think this is still a really diagnostic bubble study. And I do appreciate that the sonographer kept the at least one side of the, we might not be able to see the left atrium throughout the cycle, but we can see that there's bubbles passing.
Yeah, I think it's a good study. It's always hard for me to time exactly when the Valsalva happened, but I feel like here I can see some septal shift, which is a clue that that was probably the release phase of the Valsalva. The strain phase is usually when the picture goes out of view, right? It goes dark for a second, and then it comes back, and we see this big bolus here, which I think this bolus of bubbles combination with a good maneuver sort of seals the diagnosis for me of a PFO. It's a nice study.
It's so key, Micah, too, what you just said. Like that, the timing has to be perfect, right? You have to pacify that right atrium at the time of that release, that early release,
Yeah.
because that is when you're getting elevated pressure in the RA to push those bubbles, over. So if you don't have that, which sometimes, and we don't know, right? That's the part of the problem. It's hard to know when that Valsalva. I think there's clues like the whole heart moves, and that's probably that strain phase, right?
Right.
But it's not always apparent, and especially when it's negative,
Yes.
that's really when you have to question whether or not it was done appropriately and the timing was right on.
But this is another good example of how important the sonographers are because this is sonographer driven, like the
Oh, so
timing
much.
of the strain, now inject the bubbles, now take the pictures. That is
Yep.
all sonographer. And you could have the best Valsalva in the world, but if it's done when the contrast is already cleared from the RA, it's not going to help, so
Yeah.
it's
Yep.
tricky.
All right. Next case. So here's one. And to me, this kind of looks like in the middle of that clip, maybe they did a Valsalva. So here's the bubbles, and then it kind of looks to me like here is where the patient is bearing down and then releases.
Yeah.
So I think the
Um,
bubble quality in this is pretty good. What do you guys
but
think when
yeah,
you see that little,
Negative contrast, yeah.
yeah,
yeah.
yeah,
Yeah, that's what I was gonna. So, I mean, especially because you're not getting any bubbles really going from, right to left there. And that could be a case where you're not doing a good Valsalva, but it does look like, when you see something like that, you do question whether or not there's more of a left to right,
Mhm.
type of shunt going on that's kind of displacing the bubbles in that area.
I would think the Doppler would show it. I mean, obviously we're not getting Doppler images here, but if there were actual flow going that way, I would hope we'd see it on the Doppler. But you're right. It does make you think about it.
Yeah. Well, and these bubbles, so, even though it seems like they, obviously they were meant to just look at to see if there was a PFO, but it seemed like they didn't last long enough for them to do this maneuver in the middle of this.
Yeah.
Like they kind of stopped coming in and stopped opacifying as well mid clip. So I think this was a great injection, but the timing of the
Yeah.
maneuver seemed off.
Yeah.
Yeah, I agree.
All right, let's take a look at this one.
And it could be not the timing of the maneuver as much as the patient, right? I
Yeah.
mean, the patient might not necessarily be able to do a good Valsalva. And so you could do everything right as a sonographer, and it's just not possible. So,
Yeah.
Yeah. I mean, we're seeing more goal-directed, Valsalvas. I think that's in the mavacamten HCM world. They're big on Valsalva. I'd like to see us adopt or steal some of that because I think we need help with our Valsalvas too.
I definitely think so too. All right, here's the next clip. I just wanted to play it from the beginning so you guys got the full bubble picture here. So here's just a resting bubble study, and there are the bubbles.
Oh God.
And I don't quite know, maybe something else is going to come through. Maybe we're going to see more bubbles
Yeah.
or something. What kind of
What is
bubbles are
that?
those?
that's that is
Oh my
that is
God.
really odd. That
That
is
Is
looks
that
like Ben Fried
Are those
bubbles.
freed
that
bubbles?
that's horrible.
Jesus.
That
I mean,
I never want to see that again. First of all, that picture is from I have no idea, but where you got that, we'll just leave it. We'll leave it that way. Do
Well,
not send this out. I thought this was being recorded and people are
no,
going to have to see that again.
no, nobody's ever gonna see it ever.
We
yeah,
can edit it. We can edit it later, right?
yes, of course, Ben.
That is a Freed shunt, I think. Ben
I
Freed is
think,
all over that heart.
Yeah,
yeah,
well, it's every chamber.
it's
Every
every
and there's a
chamber.
lot of them.
And they're very agitated.
They are very
They are
agitated.
always agitated.
Yes. I would think so. In terms of this actual bubble study, though, these were pretty poor bubbles. So I'm
Yeah.
glad Ben came to the rescue with his bubbles because the other bubbles are really terrible.
You know what? I mean, this is real life. It's 8 o'clock. You would love to send the stenographer to try again. What do you say? How do you read this? I can't read this as a negative bubble study, you know?
Yeah.
Yeah.
And I think this also plays to, I feel like when I've had to train folks to do bubble studies or, perform the agitation, it really there's kind of a learning curve to it, even though it is a fairly basic, maneuver of doing those syringes back and forth. This is what happens when it's not done well enough. So it really gives for a really poor study and makes our physicians very agitated. So, all
True,
right, I'll
true
show
to the
you a
name.
better one without Ben in here.
Can
So
you warn us in the future if Ben's going to show up on the screen
Yeah,
again?
yes, please let me know. Really sad I didn't vet these images before I agreed to this.
So here is a case of this is the same patient imaged in two separate echoes. And so this patient came in. We know she has a history of a PFO, and she also has a family history of stroke. And so really getting to understand what her PFO is like and seeing if she's at risk for anything is going to be really important. So here was our first bubble study.
Nice.
Nice. So I think pretty good opacification.
Hmm. Yeah.
It's all right. What I'm seeing, whoa, sorry, everybody.
Oh,
There we go.
I thought you saw something there.
I thought, yeah. Well, I didn't know if it zoomed up for you guys too or just me. What I'm noticing here is that she's got this interatrial septal
Yes.
aneurysm.
Yes.
And since it's like fixed in the RA, I would think you'd need to do an even greater maneuver to get that to shift. Is that, am I kind of understand, possibly because if the left atrial pressures are a little bit higher, maybe you'd have to have them do a really good Valsalva or a really big cough. But here they are coming back after a year. Oops. So again, we see that septal aneurysm and hear those nice bubbles.
Oh, whoa, there you go.
Oh,
Okay.
Oh, right.
that was
That
cool.
was like a
Yeah.
hernia, like a
Yeah.
bubble hernia.
Bubble hernia, right? So yeah, so we really, one of the things that we can look for that I feel like we don't do as much is looking for this septal shift, and kind of as a sonographer using that as kind of a tool to help us say, did we do a good enough maneuver?
So yeah, I mean, I when I see cases like the one on the left, I will say it's negative, but I don't think we ever reversed the pressure gradient. And
Okay.
so, did we miss something? Yeah, obviously that's the same patient. So we
Yeah.
missed something on the left because the maneuver wasn't good. Yeah.
Ben, any other comments?
Here's a question in the chat I want to draw your attention to.
Oh, perfect.
Is the best timing for Valsalva right when you see bubbles enter the RA or right after injection?
So I'll talk a little bit to this, and then Micah and Ben, I'd love to hear your perspectives too. But when I'm having the patient perform a Valsalva with bubble study, I will have them start the Valsalva, and then that should last for about 10 seconds. At about 5 or 6 seconds is when I inject. And then when I see the bubbles come in is when I have them release.
Exactly what I do.
It's the timing thing we were talking about earlier. You want to get that the right atrium opacified and then do the release. The release doesn't last all that long, and I think you have to make sure that you got bubbles in there that can go across at that moment.
Yeah, and really, I think too, having them hold that Valsalva long enough at the beginning so that it is building up that pressure. If you just have them bear down and release, that's not going to do enough.
Yeah.
Yep.
Great
And that's,
question.
a lot of times sonographers are doing these in the ER, in the ICU. There's someone else doing the bubble. Like it's really hard to coordinate, which I think I feel I don't know what you're supposed to do. It's just hard.
Yeah. All right, so talking about maneuvers still, here's a resting study I'll show you on the left. Oops, there's my little sphygmometer.
Ah,
So here's the resting study. I think pretty good, even though this seems like a pretty challenging scan.
yeah,
But
it's a little light on the contrast for me,
yeah,
on the right side, but
but at least we can see that the bubbles look pretty uniform. It doesn't look like
yeah,
there's a couple bubbles coming in at
yeah,
once. But I would definitely say that's negative, right? I'll play it again. Make sure you
Well, it's negative without any maneuvers.
Yes, negative at rest. Yes. So, these images, this is actually a case that was sent to me by some folks at Atrium down in North Carolina, and they are using the sphygmanometer to do HCM studies, but then they've also
mm,
been trying to use it with bubble studies. So here is
yeah,
that same patient using the device. So they're kind of blowing into this syringe, and then we see it fairly mildly positive, but we did see that little poof of bubbles. So I'll watch you play that again, and then you guys see that little cloud.
yeah,
So I thought that was a really interesting way that these sonographers used, some new techniques
yep,
to do this bubble study.
So it's replicating the Valsalva part of it,
Yep.
or
Yep. So basically, instead of, and if there's some literature about this for the HCM population and using this to get gradients. But basically hooking kind of the head of a blood pressure cuff up to some tubing, and then you can attach a syringe at the end and then have them blow into the syringe. If you have them hold that at 40 millimeters of mercury for that 10 seconds, that is equivalent to that Valsalva maneuver.
Yeah, that's pretty slick.
Yeah. So I thought this was just a really interesting way to use that because I hadn't seen it actually used on a bubble study before. So
Yeah.
thank you, Cody Fry, for giving me that case.
Nice.
All right, let's get on to case 3. So this is and I guess if there's any, I'm just going to kind of keep going through these, but if there are questions, please put them in the chat. That was a great question before about the Valsalva maneuver. So case 3 is a 55-year-old male with onset of left arm weakness and a facial droop, and he presents to the ED. And they did confirm that he had a stroke on CT. So he got a TEE done. I didn't get to see his transthoracic echo, but I wanted to get your opinions on what this interatrial septum looks like. Like when you see this just in 2D, what are you nervous about?
I mean, it's pretty aneurysmal and certainly worried about some sort of intracardiac shunt.
Yeah, maybe more than one.
Yeah.
Right? Could there be
It's like a
Swiss?
Swiss cheese
There you go.
phenomenon.
I was gonna say Swiss cheese, but I
You
know
were
you
going to say
don't
different
lactose.
cheese, and it wasn't going to make sense, but that's why
No,
I'm here.
because you are lactose intolerant, and I didn't want to bring that up.
That's true. That's true.
Okay.
But thank you for bringing it up. Along with the bubbles of my picture, I really am enjoying this.
We'll be sure to have you on again, Ben.
Yeah, I'll be sure to say yes.
So looking at even just the color on this, I'm seeing this one giant
Well,
hole at least.
yeah.
And then maybe some other ones kind of down here.
But
Yeah.
what's interesting here is I'll bet you this was probably a negative bubble study, right?
I will show you the bubbles.
Oh, okay,
Watch.
whatever.
Yeah.
Sorry, I'll shut
Hold
up.
So,
on. You're agitated.
You're agitated.
so this was the first bubble study performed on TEE. Oop, not that one. Keep clicking the wrong thing, everybody. Sorry.
Okay,
All
so
right.
it's positive. All right.
Yes, but that's all you get for the bubble study.
Yeah.
So for somebody performing TEEs, is there something that you would do differently with this clip?
Well,
Maybe
Ben doesn't use sedation from what I remember. I think that helps, right?
Yeah, it does help because you can,
It's just
I
one
mean
giant
it's a
Valsalva.
little rocky at the beginning, but you can do the
But
maneuvers. So
yeah, and they
they're
can
not
actually,
sedated, you can instruct them. Although they're kind of angry at you. So it's a little mixed bag.
But they don't remember anything when
yeah,
you just say, "Hi,
and
I'm Dr. Eimer. I'll be doing your TE today." Yeah.
and they can't really talk back either.
It's
So
true.
it's
It's true.
I would say one of the things I found about this clip, this was kind of the second portion of this. I thought this first TE clip should have been a little bit longer so
Yeah.
that we could see kind of if there was, we just kind of see that one puff of bubbles, but I would have liked to see kind of continuously how they're flowing into the
But
L.
I'll say I have seen TTEs in this case that are negative because of the left to right flow. You know what I mean?
Okay.
And so you do the TTE and you're like, it's a negative bubble study, but in high probability cases where the suspicion for a paradoxical embolism is high, as in this one, you may still go on to do the TE because we miss them for this reason, And
Yeah.
it's back to again the maneuver quality, right? So if you never reverse the pressure gradient, you can get fooled with a false negative transthoracic in a case like this.
Yeah, and that's obviously this whole talk is about bubbles, but it's incredibly important to put Doppler on the septum. I
Yes.
mean, that's
Yes.
key, right? Because there's a huge left to right shunt going on here. Now,
Yeah.
this could be bidirectional to some degree, but there's It's a gigantic left to right jump.
But I would think the Doppler waveform could also help you distinguish if it was bidirectional, right? You could see that from there. So great comment. So to move on with this case, this patient ended up getting a PFO closure. So
Right.
here we see this. This is just a clip of the LA, no bubbles, but just showing this nice, probably an Amplatzer or some kind of clamshell device that we could see pretty well. And then we did do a bubble study after closure. And so here's the bubbles at rest. Pretty
Looks
good.
pretty good.
Yeah, pretty good bubble study. I would say, like, looking at these bubbles, they don't, they maybe weren't agitated enough. I feel like when I can pick out individual bubbles,
Yeah.
sometimes I think that maybe it wasn't agitated enough.
Yeah, it could be better. I
Yeah.
always wondered about this. Like, are we supposed to do bubble studies post-closure? Like, we get a ton of echoes, but we don't
We
typically.
don't
You
we don't
don't?
typically, but I think it's just because we don't want. I don't know the answer, but we don't typically do bubbles after the closure.
Yeah.
Yeah.
What
I
I've
always
heard
wondered.
from some other people in the field is that, typically especially when they implant one of these devices, it takes a little while to endothelialize. So like if you did a bubble
Yeah.
study right afterwards, it still might be positive.
Gotcha.
But so in this case, at rest, we didn't see any bubbles, but then the patient did a Valsalva, and then let me show you this. So bearing down probably, and then this is the release with.
Oh, yeah.
So, and this was probably at least a year after that closure. But if you guys remember what I had to remind myself about this case when I saw this original bubble study was that even though he had the closure, remember, and I can go back a couple clips here.
Ah, there's another hole.
Yeah, there might be another hole. So when I looked at the interventional notes, they couldn't get a guide wire through that second shunt. So, I think obviously it took a lot of pressure building and doing a good Valsalva to make this positive. But
Yeah.
this patient didn't have any recurrent events, but I would think that you'd look again at it if he did.
Yeah, you
Um,
wonder if the Amplitzer was the right. I mean, with the multiple jets, it's because then what are you really doing? I mean,
Yeah.
if this is a paradoxical embolus that caused a stroke and you close off one hole but not another,
Yeah.
yeah, but maybe because they couldn't wire it, they thought it was not significant, you know.
Yeah.
Did we give this patient a full refund and validate their parking?
I'm sure. I'm sure we
Okay,
did.
good.
All right. And then this was just to your point about Doppler. I saw just, briefly by color Doppler and then by spectral Doppler, you can see that other little shunt in the subcostal view. So I just thought this was an interesting one that like we closed the big hole, but there still might be another one there.
So what are they going to do? Do you know? Or what did they do?
They just let it be. This has,
Oh,
yeah, they didn't, he has not had any recurrent events and has been doing well. These studies were performed, I think, in 2019. So it's been a couple years. So yeah, he's doing
hmm,
well.
interesting.
Yeah. All right. Our last case, full case study is I wanted to put this QR code out there too, because our very own Dr. Micah Eimer wrote this up for Case Journal, which is one of ASC's it's ASC's journal for cases. And so congratulations for having this be submitted and be accepted. So on each of these slides, you'll see the QR code. It just takes you to that website if you want to take a look, just to give a little shout out to you, Micah.
Thank you.
So this is an interesting one of a 52-year-old female with a history of DVT and PE, and she developed acute left-sided weakness post IVC placement. And she does have a little bit more history to that, but it's not necessarily related to the bubble study itself. So I want to take you first, I want to take you back to when she was 39 and in 2009 when we did our first TEE with her. And so here is the clip. All right. So that's playing kind of over and over, but this looks like a pretty significant shunt.
Yeah.
Definitely a shunt. Look at that 2009 echo.
I know. Look at us.
What? It looks good, you
Look
think,
how
or
far
no?
we've come.
I know. I know.
Yeah.
But it's interesting that even in 2009 and then back in, 2000 into the 70s, 60s, we've been doing bubble studies the same way since then.
That's
So,
true. I
Don't
mean,
screw up a good thing, you know?
yeah. So I think to me this was also read out as a interatrial level shunt, and a pretty large one at that.
yeah, but if it was incidental and that's the patient didn't have a stroke, you would be like, yeah, so what?
Yeah.
You know?
And that's basically what happened with her. They said, "Oh, this is interesting." And then they didn't close it. They didn't do anything. So, fast forward to now, she had a transthoracic echo done, and you can see how lovely this study is. Let's let you guys look at this bubble study.
I don't even see like half of the heart.
Such a pain, man.
You mean you didn't see any of the bubbles that came in, but it's
I
positive.
see bubbles
No,
there.
I see bubbles, but I don't know how they got there.
I don't know how they got there. I didn't even see bubbles come into the right heart. I don't know where they're from.
She
Wait,
Um,
invited
Maddie, she did
them.
have a stroke or she didn't have a stroke?
no.
That right-sided weakness was not a stroke?
Oh, that is now after her. So, and maybe Micah,
Oh,
you can do a
oh, oh.
little
This
back.
that
Yeah.
was
Yeah.
2009 was before all of that
Yes.
happened.
Yeah.
Okay.
So
So
then she
now
has
she
this,
has come in after IVC placement and she has had some stroke-like symptoms.
Okay.
and we're trying to figure out why did she have a stroke? Yeah.
Okay,
Yes.
okay, okay, okay. Got
Yeah.
it.
Yeah. So we see some bubbles. We know this is positive, but we don't really know where. So they, of course, ordered a TEE because it seemed like maybe there was some artifact, maybe some from like breast implant or something else on that echo. But that was a really challenging transthoracic study. And so here is the bubbles on the TEE. Ooh, and they're kind of trying to look towards the back there. It's going to play again in just a moment. But, when we're talking about bubble counting, I guess, these bubbles show up within like 3 beats,
Yeah.
right?
And it's hard to count all those bubbles.
I know. I don't
You
think
mean
I
just
would.
the timing of it. They show up really quickly.
Yeah. And like I'm seeing like yeah, I'm not convinced that this is like opening for a flap, but I'm still not, I need to see more, I think. Micah, what do you think?
Yeah. I mean, it's very quick, right? You're like, this is super quick. This must be intracardiac.
Yeah, but
Uh,
there are bubbles coming in through a vein there in the in the left atrium. Like look at the right side. I mean, I think that's do you
Like,
see there's like a shot of bubbles coming out, right? I can't point, but it's on the right side of the
okay.
screen.
Yeah.
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 So maybe it could be something different. So this patient ended up having a CT scan to rule out PE in all of this. And we saw she had this giant PAVM. So these bubbles were, it was positive, but this is more from this PAVM than it was from she didn't have any type of interatrial shunting. So what they ended up doing was they took her to IR and they put in a coil to kind of seal off this PAVM, or at least to prevent it from, being as big of a shunt or, letting septic emboli pass through. But then this TEE was done post coil. So here's the bubbles looking at the septum. So, and then here I feel like now we're seeing the late bubbles.
Just a couple, yeah.
Yeah, and but this matches up more to that PAVM than before. And then our very astute TE sonographer Micah also did a a view of the pulmonary veins with this bubble study. And so I thought this was really interesting view that you don't typically see on a TE of these bubbles coming right from that pulmonary vein.
Do you do that, Ben? You ever try to image the pulmonary veins and catch bubbles coming out of them?
Yeah, no, I mean, yes, because I mean that definitely could be help you to differentiate between an intracardiac and an extracardiac shunt. I also, you wonder too if there's like, an anomalous, like a partial
Yeah.
anomalous or total, anomalous pulmonary vein with like a sinus venosus ASD. I mean, that's also kind of in the back of your head. If you see a shunt and it could be intracardiac, but you don't see it necessarily like a secundum ASD, you want to look elsewhere and see if maybe there is a sinus venosus thing going on.
Yeah. I think the other thing for me was on that TE, if you're going to say that it's intracardiac, I like to see the tunnel, right? Like I'd like to see a little more evidence that there is a potential space there.
Yeah.
Was there anything in particular, like with this view that you have on the right, is there any, like, I'm not quite, not being as familiar with TEE, is there a specific pulmonary vein that you try to image? Or, because I know we can see a couple of them on TEE, but I guess like just for those, on the call who might try this on their next TEE, or just kind of seeing any pulmonary vein.
I'm happy to see any of them, honestly. Um, I mean,
Yep.
if I can get one, all right, that's fine. Two is like, oh my God, it's my
You you
birthday.
might as well go home
Because
and
that's it. Drop
yeah,
the probe and walk
drop
out,
drop the
you know?
probe.
Oh, that's great. Well, congratulations again, Micah, for getting this case
Thank you.
accepted. You guys can go again, scan the QR code or go to case journal at ASC and go look up this really interesting case. You can see some more images with it.
And I think, Maddie, it just real quick, it just, PAVMs can cause stroke too. Like PFO
Yeah.
is not the only shunt that can cause stroke. And, if you think about in the HHT population, hereditary hemorrhagic telangiectasias, it's a big problem for them. I mean, they have a lot of large pulmonary AVMs. This patient did not. Although, if you find a large pulmonary AVM, you should test the patient for HHT. But in
Mhm.
that population, they get strokes, and it's because of pulmonary AVMs, which can be very hard to differentiate on the classic, like how many cardiac cycles, because they're big, right? And so you
Yeah.
can see bubbles very quickly.
I think this also raises the idea of this timing issue. I mean, we
Yes.
still very much take timing into account and say if it's early, less than three cardiac cycles, it's probably intracardiac, and if not, and it, this case and the previous case, although I think there was two things going on, like it's not that clear cut. I think being able to really see the septum, to see the veins, it's helpful. It really
Yeah.
is in differentiating where the bubbles are actually coming from.
Yeah, and when you do the maneuvers, right? Like it's the time, it's relative to the maneuver, not relative to when the contrast came in, right? Like you
Right.
like to see Valsalva release, contrast, you're like, got it. You know what I mean? I couldn't agree with you more.
Awesome. Okay, last couple of studies, just some rapid fire cases
All
as
right,
we've
let's
got
go.
about 9 minutes left. So here, we've got bubbles. It's kind of hard to say rapid fire when the bubble studies take a while.
Hmm.
I feel like I'm on a game show.
I know. Rapid fire bubbles. So what do you just notice about this bubble study and what could be going on here?
I mean, looks to me like a lot of TR.
Yeah.
There's
I almost
so much going on. There's color Doppler, there's bubbles.
Who pressed all these buttons at the
Why?
same time?
Just one thing at a time.
one thing at a time. Yeah. I think so this, yeah, talking a little bit about this, just the TR, I think is what is interesting about this. It almost seems like it's going towards the septum.
Yeah.
So do you think that's a reason why bubbles might not go right by the interatrial septum?
That's possible. I mean, it's displacement, right? I mean, the bubbles are trying to get to that place and they can't for
Yeah.
whatever reason. I mean, sometimes you got a big like eustachian valve or something, and you can see, especially on TEE, like it's blocking the shot. It like will not let the bubbles get to that area.
Yeah.
So yeah, I mean, anything that is kind of interfering, it's hard. You really have to opacify that area, and like it has to be a good injection.
And
Yeah.
like Ben said, if you look around the septum, there are very few bubbles there.
Yeah. Yep. Exactly. Okay, cool. Next one.
On the
Rapid
other
fire.
hand, I would say the TR probably increases the right atrial pressure, which helps you. You know
Okay.
what I mean? Yeah.
Ben, this one might be right up your alley with your background in pH here.
Uh-oh.
Ooh.
What do you, what even is that?
That is a right heart that's eating a left heart.
Yes, yes. And
Yeah.
then
It's the
with
eating left heart sign.
Oh my God.
yeah. I
I
thought
mean, there literally is hardly any left heart.
I know. And I couldn't figure out if this was one like the other one that maybe had a secondary shunt to it, maybe maybe the pressures are pushing this thing out. I don't know, but I also didn't think, I thought that probably the RV pressure and there was quite a bit of TR. When we look at the RV, I don't think it's very well opacified. So
Did
even though
someone
it's
like, was
positive,
this supposed to be a septostomy or like, what is there? There's a device in there.
yes,
Mm.
yeah.
Look at that moderator band, man. I mean, that RV has been working.
Yeah. I thought it was interesting though that it was still, and I guess to your point about the increased RA pressures, that it's still positive, even though the right side doesn't fully opacify. Like,
Yeah.
we don't see a
Yeah.
whiteout.
Yeah. It's just
This,
such a high pressure. I mean, it could be systemic pressure. Who knows? Who knows?
Yeah.
yeah.
All right.
This,
Well,
this RV looks like Freed on his last day of service, of inpatient service.
That- Unfortunately, these days it doesn't have to be my last day.
good.
The first
Yeah.
day?
It could be the first hour of the first
Yeah.
day.
It could be anytime. All right. What about this one? Here's something weird.
Is that that's a eustachian valve, I think, huh?
Yeah.
Yeah. And then
Yeah.
here's the bubbles, kind of late bubbles here.
Just trying to
Yeah.
block it.
Oh, yeah.
All right, this is a good one, Maddie.
This
I
is
think those are pseudo bubbles.
in the LA?
Yeah.
Yeah. Like,
I don't know what that means exactly, but I think it's an artifact. I mean, that's what I think. I don't know. What do you think, Ben?
Yeah, I mean, we see this a lot. I don't know. I feel almost like a lot more than we used to, but there's just this like shadows of bubbles that are
Yes.
in the left atrium, and are they real or not real? I mean, you don't see any entryway. I mean, there's no clear PFO going on
hmm.
here, so
I felt like
it,
maybe it could be coming from like over here, but
But they're so
also
linear. They're
it's
like
like the
lines.
sludge.
Yeah.
It's like, it's so,
it's almost like a lighter version of the bubbles that are coming into like it's a softer version of the bubbles. Like it,
yeah.
it's not as bright as what's happening on the right side of the heart.
Yeah. And I would expect that if it was positive to see the same I don't know, consistency of
Yeah,
bubbles
same
and or
density, same,
Yeah.
yeah.
yeah. All
I think
right.
it's an artifact. I don't know what it's called. I don't know why it's there, but it confuses us for sure.
It sure does.
But this is another example of if you really don't know, right, then look to where it might be coming from. Look at get other views of the septum, look at the veins or the one vein that Micah can pick up, like
Yeah. All right. I will end with this will be our last case and sorry about it. I'm just gonna say that. All right. There's
I don't like this at all.
there's a bubble study.
You should have not ended with this.
I
Maddie.
Well, this, I feel like this happens more often than we know, when you guys are reading. Obviously, for a sonographer, you've got the patient who has no apicals, and so you had to do it from a subcostal. You're in the ICU with your uh, thing for
Isolation
yes,
gown.
isolation
Yeah.
gown. Yeah, you're sweating,
PPE.
you've got sweat in your eyes, and this is your your bubble study.
Well,
So,
credit to the sonographer for going subcostal, right? Because
yeah.
sometimes, right, like that's good work there.
Yeah. Yep. All right. Oh, I guess I did have one more. Okay, I'll show you this. This is a good one, so I'll show you this one on the right. This was a very nice Valsalva. It's a little slow playing, but we can really, even though it's very slow, come on. There we go.
Oh,
But here we see that septum shift and a really nice Valsalva. So I did want to end on a good study.
thank you.
This is really, yeah, this is good. This is decent. And it's decent of you, Maddie.
Yeah, you're welcome. You're welcome. So with that, let me pull it open. We just have a couple minutes for questions, but I hope that you were able to put them in the chat if you had any while we were chatting. All right, we'll kind of keep it open for a moment. I'm just going to put this last slide up here. Thank you again for those of you who joined us tonight. This was really fun. Ben and Micah, thank you for being here and taking the time to do this with me tonight. I think it's really important to talk through the challenges that we have with bubble studies, but also have an opportunity to bounce things off of colleagues like we do in the lab. And so I just appreciate both of you. So thank you.
Thanks,
Thank you,
Maddie. This
Maddie.
was a lot of fun. I look forward to the next one, Ben, if you don't mind.
We'll see.
We'll
I want
see.
to see the image. I want to see the cases beforehand. So
Ah,
that'll be in my contract next
That'll
time.
be in your contract.
Yeah.
Perfect. And
Well,
then
That and red M&Ms only.
good, yes. Um,
there,
Also, just please remember at the end of this, a CME survey will come out for sonographers. Please make sure to put your email and then it'll ask for your number, like your ARDMS or your Sonography Canada number. Please put that in. That is how Martin is going to get you your CME credits, and make sure your email is a active email so that he can email those to you within the next couple weeks. Also, just a couple announcements. Please follow us on social media. We're on LinkedIn right now at Agitated Solutions. And if you're going to be at ASC, we will have a booth 330. Come on by, look at some bubbles, try out some cool products, see some, chat bubble studies with the group. And we hope to see you soon.
thank you.
Thank you.
All right. Thanks, everyone.